My name is Raj Gala. I'm an orthopedic spine surgeon with ONS, and I wanted to give you guys a quick talk on spinal stenosis. Typically, when we talk about spinal stenosis, we're talking about the lumbar spine and the low back, and that's what I'm going to focus on here. It is the more common area that we see. So classically, when we associate spinal stenosis with symptoms, we think of neurogenic claudication. There are other forms of claudication, specifically vascular, but this is a neurogenic claudication. And people typically complain of buttock and leg pain when they're walking, when they're upright. They aren't able to stand up straight. And you can see how that might be confused with vascular claudication because they would also complain of leg pain with activity. So there are some ways to differentiate between the two, such as checking pulses, either by palpation or Doppler to make sure they have good vascular flow. And then typically, one question that I ask patients are, if you have no pain while bicycling, that would be a sign that, okay, maybe they don't have vascular issues. Or if their leg pain goes away when they, if they have leg pain when they put their foot down, even when they're sitting, that could also be a sign of vascular issues. So another test or sign that we look at is a shopping cart sign. So people that have to lean on a shopping cart, leaning forward, because that tends to relieve some of their buttock and leg pain. So what are some causes of spinal stenosis? The number one cause is degeneration of the spine. We have many joints in our lumbar spine. You have your discs, your facet joints, and they can enlarge in. You can get disc protrusions. You can get hypertrophy of ligaments in the spine. And together, those can narrow the space available for your lumbar nerves. And so the most common cause is degeneration. There are other causes, which I've listed in order of decreasing frequency, which can be found in other patient groups. And of course, we always have to keep an eye out for some of these other concerning causes down below. There's a picture here of an MRI of the lumbar spine. The spinal cord usually stops up here around L1, L2, and then we call that the conus. So below that is the cauda equina, which we call the horse's tail. And so those are really just nerve roots down there. And you can see down here at this level where there's compression on the cauda equina nerve roots, and there's a little bit of redundancy in the nerve roots, and we call that the sedimentation sign. So spinal stenosis is really a imaging class diagnosis. It's not the neurogenic claudication is the symptom diagnosis. So you can have spinal stenosis and not have symptoms. And some people can actually have symptoms of spinal stenosis with kind of mild to moderate stenosis on finding. So sometimes they don't always match up. So how do we diagnose spinal stenosis? Typically we get an x-ray. It's just often a first-line test. We can see someone's alignment when they're standing compared to some of these other tests which are done supine, so you can get a little bit different picture with that. And it's also often needed for insurance purposes. You can get a CT scan with contrast injected into the spine, and that's that picture on the bottom left. We usually use those if someone can't have an MRI for some reason, or we are looking at very specific conditions where we need contrast in the thecal sac. The middle is an MRI, and that's an example of a disc herniation causing spinal stenosis. And the right picture is an example of degenerative condition causing spinal stenosis. And if you can kind of make out where one bone is a little bit slipped over the other bone, and that is a condition called spondylolisthesis, which is sometimes also associated. So what are the main treatments? So typically, first line is always conservative, conservative, conservative. There's a lot of different treatment options that people try. You've got physical therapy, activity modification, weight loss. Those are always worth trying in these conditions. People try different medications. We've talked about NSAIDs before for calming down inflammation, for treating pain. There's also neuromodular medications such as gabapentin and pregabalin if people have a lot of nerve pain associated with this. And then we all know about epidural injections as well. There are many different kinds of epidurals, but the basic one is called an interlaminar, where a physiatrist such as Dr. Heffler can put some medicine into the epidural space to calm down inflammation around the nerve roots. It's not going to get rid of the stenosis, but Again, usually inflammation is pain, and if we can get rid of inflammation, someone might not have pain with their spinal stenosis. So when do we move on to surgery? Not every case goes on to surgery. There's a lot of cases we can follow for many years. Their symptoms are not so bad that surgery is worth it, because sometimes the treatment can be worse than the disease. So typically, we want to have seen someone try at least 6 weeks of conservative treatment. Typically, it's going to be much longer than that, because typically the symptoms will take a while to progress. They don't come on all of a sudden. If someone has any weakness, and especially if it's progressing, that's definitely an indication to consider surgery, because that tells us the nerve roots are under a lot of compression and having motor weakness. And if there's this dreaded sign of cauda-equina syndrome where there's loss of bowel and bladder, that's an indication for emergency decompression right away. So what are our surgical options? We've got a few different options and a few different ways to do them. The classic surgery is laminectomy. That's the one that has been done for many, many years. We now have minimally invasive ways to do the laminectomy. You can do them through a tube, and we call that tubular surgery, as well as endoscopic with the machine, and I'll show you some pictures for that later. And this latest one is now called Vertiflex, and I'll go over that as well. I put a little bullet down here for fusion. I'm not going to go into that here. There are some indications to do a fusion at the same time as well, but that's usually for instability and doesn't fit into the whole spinal stenosis talk right now. So for a laminectomy, what you're doing is basically unroofing the spinal canal. So on the back part or the dorsal part of the spine, we know from mechanical studies that you can remove a certain part of the lamina without destabilizing the spine. And so this picture at the top left shows that midline laminectomy, and then the spinal cord, or the nerve roots, which are the yellow, have more room to breathe. The picture on the bottom shows a tubular version of that, where you can make a small incision and put a tube down, but you're looking directly through the tube, either with your loupes or with the microscope, and you're doing the decompression that way. And then the last picture on the right is an endoscopic version, where you're actually putting a camera device down and you're looking at a screen, but doing the same work directly on the spine. We don't really call this true arthroscopic or laparoscopic. Patients sometimes ask. It is endoscopic, so it's not going into like a joint space like arthroscopic would be. And now this Vertiflex option is kind of the newest option, and not everyone's really a candidate, and goes more into this wide awake stuff that we talked about with the hand. It's a small device that's put in the spinous processes in the back, and can be done awake, under sedation, or even under general anesthesia, depending on what the patient wants. And the goal of that is to prevent collapse when they stand up, so that there's still some room dorsally in the back. It's only FDA approved in the lumbar spine, and it's only approved for 1 or 2 levels at a time. Typically, one level takes about 30 minutes. Adding a second level adds another 15 minutes for 45 minutes. There is fluoro. You have to use fluoro to put this in. And it's technically FDA approved for mild to moderate stenosis, but in my practice, I would say it's more often used in severe stenosis in patients who don't want to have open laminectomy or any other type of laminectomy surgery. The benefit of this procedure is that you're not burning any bridges. This can be removed if needed. And worst case scenario, if you put it in and it doesn't work, you can still go in and do a laminectomy afterwards. But the results on this have shown that for about 2 years, there can be some durable relief of their neurogenic claudication. As you can see, because you're not removing any bone or doing anything permanent to the spine, you could still progress in your spinal stenosis, and you might still need something else done later, but it can be useful in those patients who may never end up needing something else down the road. Thank you.